So you are correct. The mainstay of therapy for anyone with an acute PE is anticoagulation. And the STORM trial was particularly looking at those with intermediate high risk, so those that are straining their heart both on imaging and biomarkers. And it was looking at anticoagulation alone versus anticoagulation plus mechanical thrombectomy, in particular CAVT. And so when we think about treatment, it's not just pulmonologists, although I know this is for pulmonologists, but hopefully many of the institutions and providers that are watching this have pulmonary embolus response teams, and pulmonologists are part of that team. And and we know that PE covers all different specialties. And so if the pulmonologist is the first person that's being called to assess the patient and determine what treatment they should get, I think knowledge of the STORM PE trial is very helpful because this is the first randomized controlled trial to actually show that an intervention can lead to early physiological recovery and 90-day long-term improved functional outcomes. So I think it actually opens up a really great opportunity for pulmonologists to share with their patients to say, here's this trial. We can proceed with anticoagulation alone, which has been the mainstay of therapy, and you're going to get anyways. But there was this recent trial that actually showed if we do this intervention, you could recover faster, so early physiological recovery, and have better 90-day outcomes. So I think like I said, it's great for patients and pulmonologists to have this now as an intervention, an opportunity to improve patient care. So I think it adds to patient care, and I think it can really change how we approach patients with this risk PE. Yeah, thank you for that question. So, when patients present with an acute PE, our primary goal is to make sure they don't die of their PE, make sure they don't bleed from the interventions or have some other adverse outcomes, and make sure they leave the hospital and don't come back with another blood clot. One of the things that has been highlighted, not recently, but it's been a real issue with PE patients, is that PE is not just an acute illness. There's long-term complications, as you're alluding to, kind of post-PE syndrome, and that can include things like ongoing shortness of breath or even CTEPH or CTED. There's a whole spectrum of that. And so one of the thoughts is if you intervene early, would there be long-term complications and long-term benefits that could possibly decrease one's chance of developing one of those post-PE syndromes? And so this trial showed that there was early physiological recovery, what you mentioned. So decreased oxygenation requirements, decreased heart rate, decreased thrombus burden, and then the new score, decreased likelihood of deteriorating and needing some other intervention. The 90-day outcomes, which are the PVFS and the 6-minute walk test, indicate that um, improvement in the strain on the right heart had longer term consequences, i.e., at 90 days. And interestingly, at 60 days, although the people that received the intervention were able to walk farther, there was no statistically significant difference between those two arms, but at 90 days there were. So whether this translates into decrease CTEPH and CTED, we don't know. We don't have that data. But what it does show is that people are getting back to their functional status faster and that they're having improved functional outcomes at 90 days. And it's obviously everyone's hope that it could improve, it could lead to some other improvement in terms of the post-PE, but we can't make that connection yet because we don't have that data. And I think it will just, as our trial gets adopted and people start offering this as an option for patients. And as the other trials, so there's a few other randomized controlled trials that are looking at this exact space and interventions in this, I think it's only going to add to the literature. And we're going to know more and more over the next year or two. Well, if you think about a blood clot, So it's usually about 80% of them start in the leg, break off, go to the right side of the heart, and then unfortunately go into the lung, and then it gets stopped there. And so if you think about the clot in the lung, it's putting a lot of pressure on the right side of that heart, having the blood pump from the right side into the lung. If there's a blockage, you get pressure. And so by relieving that pressure, and so that was indicated by relieving that strain, I should say, and our primary outcome was the decrease in the RV-LV ratio, which is an indication of right heart strain, which we know is also correlated with deterioration and mortality when you have that. By relieving that and having those, and we showed by relieving that, so decreasing that strain on the heart, patients at 48 hours were on less oxygen, were less tachycardic, had lower heart rates, had lower thrombus burden, and had less likelihood of deteriorating and potentially needing rescue therapy. So I think that you're removing the strain on that heart. You're taking out the mechanism, the clot, which was causing so much of that strain on the heart, and you've relieved it very quickly. And so that is what we're seeing in those early physiological recovery and parameters are indicating that you've done that. And that I believe that that's the mechanism. Yeah, so whenever you have a new therapy and you have a randomized controlled trial comparing it to the standard of care, the key issue is safety. And I think what is truly remarkable about this study is that there were no differences in safety between the two arms. They were comparable in terms of safety. So I think people should feel quite comfortable using this and knowing that the safety outcomes and safety issues are not going to be a significant a significant reason not to offer it. And in fact, it was 100% successful with minimal blood loss. The procedure time was very, very short, and there were no device or procedure related adverse events, which is huge because if there are, then you kind of like, well, is the benefit worth the risk, right? So it's all about risk and benefit. And so if you have an intervention that is really successful and really benefits the patient, has all these improvements, but is at the cost of some adverse safety events that really raise, then you got to figure out that balance. But the fact that the two arms, the anticoagulation arm and the anticoagulation plus mechanical thrombectomy had comparable safety profiles, I think that is very reassuring to anyone talking to patients about this trial and can share that. Yeah, so I think whenever a PE patient presents, it's always individualized, right? It has to be individualized therapy, and you need to take all of the considerations into account, including everything about the patient. I think what is unique about PE is the pulmonary embolus response teams, where you have a lot of different specialists weigh in and be able to share. I'm worried about this. Oh, this patient has this. I think the Storm PE is uh, one step towards really helping us improve patient care, right? We've waited 10 years for a trial like this, and no trial has ever looked at mechanical thrombectomy plus anticoagulation in terms of those functional outcomes that I mentioned. I do think that this gives pulmonologists uh, knowledge and information and reassurance that having this technique can really get their patients to improve faster in terms of the physiological recoveries we talked about, and potentially and have these improved functional outcomes. I think that our first paper came out; it was published in Circulation, and we will be publishing our secondary outcomes. And I think when providers make decisions about what they offer their patients, it really has to do with, is there level one evidence to support this? This is level one evidence to support this. So I definitely think it allows pulmonologists an opportunity to provide this as a treatment for their patients. What else do we need? Well, this is the first trial, and I think that we can only welcome the other trials. And the other trials are a little bit different. They have different outcomes, some of them even with different populations. I think those will add to our knowledge and understanding. Again, this is the first one. We now have level one evidence. When we think about changing practice with pulmonologists and even other providers, what do they need to change practice? Well, they need level one evidence. And then they need to look at the guidelines and see, is this what the guide is this being supported by the guidelines? Unfortunately, guidelines lag behind when the trials come out, as you probably know. And so I don't think the guidelines are going to change tomorrow based on our publication that came out a week ago or 2 weeks ago. But I think our trial, our level one evidence trial, as well as the other ones that come down the line, are only going to add and allow us to think about how those guidelines should change. So I think pulmonologists, this trial now gives them information and really kind of evidence to show their patients and demonstrate to their patients and share with their patients that this is a therapy that really can help them.